So now I'm delighted to welcome our first panel to the stage, and they'll be focused on mental health, access, and quality, and they'll be moderated by our KP leader, Dr. Andrew Bindman. Dr. Bindman is Executive Vice President and Chief Medical Officer for Kaiser Permanente. He's responsible for driving superior quality and equitable health outcomes through the integration of quality, innovation, care delivery, and research in collaboration with the Permanente medical groups. Prior to joining Kaiser Permanente, he spent more than 30 years on the faculty at UCSF, where he practiced and taught internal medicine while conducting research on health access and outcomes. He was elected to the National Academy of Medicine in 2015 and to the Association of American Physicians in 2021. So with that, let me go ahead and hand it over to Dr. Bindman. Thank you.
Okay.
Thank you. Go ahead.
I was told I'm supposed to sit in the middle. Are we in a certain order?
Wherever you're comfortable.
Oh, maybe
Well,
we should all move
thank
over.
you for the lovely introduction, and good morning, everyone. It's great to see you, and thank you for the opportunity to be here to be able to moderate what I think is going to be a lively panel. I'm joined this morning by three really distinguished guests and really treasured colleagues that I've known for many years. I'm going to introduce them and then maybe say a few comments to kind of set the scene for the discussion that follows. So let me first introduce my panelists. To my immediate left is Dr. Harold Pincus, who is a professor of psychiatry and healthcare management and policy. He directs he co-directs the Irving Institute for Clinical and Translational Research at Columbia University and the New York State Psychiatric Institute. In addition, he's a co-chair of the National Quality Forum Standing Committee on Behavioral Health and the World Health Organization ICD-11 Committee on Quality and Patient Safety. He's held a number of previous roles at RAND, Pittsburgh Health Institute, and most notably was involved at the American Psychiatric Association, where he founded the Office of Research at the National Institute of Mental Health, and he's also served as a White House and congressional staff through that office as well. So he's also, I just want to say, practicing. So for 22 years, he worked an evening a week in a public mental health clinic caring for patients with severe mental illness. So has tremendous policy experience, academic background, and patient care experience. To Harold's immediate left is Dr. Dora Hughes, who's currently the acting chief medical officer and acting director of the Center for Clinical Standards and Quality for the Centers for Medicare and Medicaid Services. That office, sometimes known by others as CCSQ, that center executes on national quality, clinical quality and safety standards for healthcare facilities and providers, and establishes coverage determinations for Medicare beneficiaries. Dora previously served as the Chief Medical Officer at the CMS Innovation Center, as the Counselor for Science and Public Health at the Department of Health and Human Services, and an Associate Research Professor at the School of Public Health at George Washington University, and had previous roles at the Commonwealth Fund, and really has a long and distinguished career in the area of quality measurement. And then next to Dr. Hughes is Dr. Sherry Glied, who is the Dean of the New York University's Robert F. Wagner Graduate School of Public Service. Previously, Dr. Glied was a professor of health policy and management at Columbia's Mailman School of Public Health and the chair of the Department of Health Policy and Management. I had the pleasure of working with Dr. Glied when she was the Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. She's also been a senior economist for healthcare and labor market policy on the President's Council on Economic Advisors under both Presidents Bush and Clinton. And her areas of expertise are in health policy reform and mental health care policy. So you can see from those very distinguished bios from our speakers that we've got some real experts here in the room to hear from, and I'm very much looking forward to their comments. But before we get to them, let me just say a couple of things about what to maybe listen for in their comments. I think we're going to talk a little bit today about the role of healthcare measurement as a way of driving improvement in mental health and wellness care. And here's how I would sort of describe, in my own words, the state of healthcare measurement today. Healthcare measurement evolved in many ways out of the work that happened at what at the time was the Institute of Medicine, now the National Academy of Medicine, when it set 6 dimensions of what quality of care is all about. And I think all of you know these probably quite well. It's effectiveness, efficiency, timely care, patient-centered care, safe care, and care that is equitable for all. Well, the good news is that since setting that set of dimensions of what makes quality of care, we've embarked on a journey to try to figure out how to measure quality of care. And the good news is that we've formed some consensus around measurement in different aspects of care, including mental health and wellness to some degree. But I guess the bad news from my point of view, and something that I think we'll probe today, is that a lot of that consensus has formed around measures that aren't entirely getting at what many people in the public and what many providers would identify as truly at the heart of what matters the most. And what matters the most for many people are the outcomes of care. Where we spend a lot of our time measuring are the processes, the things that we're doing, as opposed to what we're achieving. And this has particularly been a vexing issue, I think, for mental health and wellness care, where there have been challenges identifying these kinds of measures. And there's a real reason why not only the outcomes most important and meaningful, but I think without measuring outcomes, we're also really struggling with our ability to achieve health equity. And that's in part, I think, because when we focus on processes and whether processes are equal, in fact, the Institute of Medicine had a report called focused on equal treatment. The problem with the focus on processes and whether care is just equal is that it doesn't attend to the fact that people start in different places. And so that just providing the same care to everyone isn't necessarily going to allow everyone to achieve optimal health and their best possible health outcomes. And so without focusing on outcomes, we don't take the whole person in mind and consider some of the other factors that contribute to what really matters to them most in terms of maximizing their health. And so without a focus, I believe, on outcomes, we can't achieve one of the important dimensions of quality, and that is equity. I think that when you have a system like we have at Kaiser Permanente, and as we're talking about more broadly today about moving toward value-based care, we start to have an alignment and an opportunity to perhaps bring those factors around social determinants and a focus on outcomes to create greater alignment to focus on that. And I think that is one of the things that I would hope our panelists might comment on today. Because when one is working in a value-based environment, the goal is to keep the population healthy rather than to treat them with lots of things when they're sick. And so by doing that, one is naturally attending to all the things that contribute to keeping people healthy, not only the things that one can do in the care delivery setting, but also how one can attend to some of the social determinants like food security, housing stability, transportation to be able to get to care, open space to be able to exercise, all the things that we know contribute to healthy living. And so these are things become very important and become more of a focus, I believe, in a value-based model, such as the one that we have at KP, but that is emerging and is being, I think we'll hear about from CMS remains a focus of a lot of the work that they're doing. Now, I say all this, I've laid out sort of the hypothetical benefits, if you will, of shifting to a focus on outcomes and why it's more important for our patients, why I think many providers, in fact, think that that's what they're in the business of trying to attend to, and what I think ultimately is important for equity. But there are real challenges in being able to do this and to be able to measure it effectively, having to do with the way we capture data and the way we assemble data in our different environments of care. So recognizing the scale of this challenge, I am going to turn to our three panelists as true experts who've thought about these kinds of issues and to do a little bit of reality testing for me and for all of us today about what are the opportunities ahead for us as we try to shift toward value-based care, particularly with mental health and wellness in mind, and what are also going to be the barriers that we need to overcome to be able to truly provide care of the highest quality that meets all 6 dimensions of what the Institute of Medicine laid out, including equitable care for all. So with that, I'm going to turn it over now to our first speaker, Dr. Pincus. I think you'll be leading us off. Is that right? Yeah, sure. So please. Yeah, thank you.
Delighted to be here. I'm not sure how I advance the slides. Do I just say advance them? Oh. I see. Okay. So as I think about it, I agree with everything that Andy was talking about in terms of what we need to do and where we need to go. But we look at the challenges ahead. I think I group them into sort of 5 major categories. One has to do with access, actually people being able to receive care. And there's a lot of barriers that they face in trying to get that. And I think Teresa earlier had really alluded to some of those. Number 2, as Andy just said, there's the issue of equity. And there's all kinds of dimensions of equity. And one of the things that we sometimes forget about is equity across a disparities population that's part of the mental health field, which is people with severe mental illnesses who die 10 to 20 years earlier than the general population. Number 3 is quality, and I'm going to talk a little bit more about that, why I think that's in some ways an underlying issue in terms of the key areas that we need to address. But also another underlying issue is the fact that we have a tremendously fragmented kind of care system. I mean, if you think about it, in the start off of what Teresa was talking about from 1913, one of the key issues that were to be addressed by at that point, I can't remember what the name of it was, before there was a Mental Health America, was actually to try to integrate care from both general medical care and also mental health care. And we're nowhere close to doing that even today. In fact, it's gotten even more fragmented because most states have a separate substance abuse agency from a mental health agency. So things are really getting quite fragmented. And finally, I think the answer to each of those questions, 1 through 4, is issues around accountability. Accountability both in terms of being able to measure things so that people can not only be made accountable, but they can also improve the kind of care they're providing. Number 2 is to provide incentives to actually have it be meaningful to people, to actually make a difference in improving quality, either through providing incentives through value-based payment or by influencing regulations. And the recent change in the parity rules, or the proposed change in the parity rules, is one way of enforcing different kinds of changes to occur to make things work better. And there's several actions that can be taken. One is integrated care. There's been many, many attempts to integrate behavioral health care and general health care, going back literally centuries. And right now, we're not really enforcing that in a clear way. Going back to my point about sort of earlier about accountability, when I talk about accountability as a shared accountability, so to be sort of, to be more specific about that, if I'm a psychiatrist who's treating somebody with both schizophrenia or some other psychotic illness who also has diabetes, I should be accountable for both the outcomes for their mental health problems as well as for their outcomes for diabetes. as should my colleague, the diabetologist or endocrinologist or primary care provider. They should also be accountable for both the behavioral health aspects as well as the diabetes and other healthcare issues. If we're both accountable, that means we have to talk to each other. And that's exactly what I mean by shared accountability. And so that's why we need to get a more integrated approach. In terms of workforce, we clearly don't have enough people that are available to actually provide the care that's needed for our country. Right now, I run a national program on health and aging policy fellows, and we're focusing on aging in that. And each year, our country puts out 50 geriatric psychiatrists a year. We could quintuple that, and it would be decades, if not centuries, before we made a difference. We need to think about how we develop a workforce in a much more rapid way. And this means thinking about not just physicians and fully trained therapists and psychologists, but we're thinking about what really makes a difference in terms of what I might call the interstitial workforce. Because the biggest problem we have in behavioral health is that people fall through the cracks. How do we make sure that there's kind of a ruthless follow-up to make sure that people stay in care? And we don't need necessarily psychiatrists to do that. We need to have people that have been trained, peer support people, other kinds of people like that, to be able to engage people and keep them in care and to assess how they're doing. Right now, we don't really have that in place. We have a very, like a Tower of Babel almost, in terms of the different categories of different types of people in the workforce. We need to have a better typology that can be used. We need to have an ontology of the different tasks that people need to be trained on. And then we need to make investments and have leadership in certain areas, developing quality metrics. We really need to do more in the area of behavioral health informatics, including AI, but actually just collecting and maintaining the data so that it's accessible for improvement. We need to make up for the high-tech exclusion. The High-Tech Act gave resources to hospitals and physicians to obtain technology. Non-physicians and non-hospitals like community mental health centers were not given those resources. We need to make up for that. We need to test new models and technologies. There are a lot are becoming available, but we need to do more in terms of actually assessing and evaluating how effective they are and how to implement them more effectively, and to provide technical assistance for doing that, and also to provide parity enforcement. Andy alluded to the Institute of Medicine and the Crossing the Quality Chasm report. There was a separate report following that in 2006 that I was a participant in. It's remarkable when you look back at what our findings were and what the recommendations were, how much our findings still are the same, and how little has been done about the recommendations. So if you look, one of the things that was identified there is that we have a problem in terms of the nature of the behavioral health industry, so to speak. For a large portion of the behavioral health industry is a cottage industry of people working in individual practices with little infrastructure and with little connection to other parts of the healthcare system. It's still the same. Several years ago, we published a paper showing that 65% of psychiatrists don't take Medicaid. More than half don't take Medicare. Most of the cottage industry we're talking about is people who are professionals who do not take insurance at all and have essentially no accountability elements built into their practices. A large portion of what we're doing is now we're not actually doing measurement-based care. We're not actually seeing directly how patients are doing in a systematic way and making judgments about how to provide care based upon whether people are improving or not in a with systematic longitudinal assessment. We need to do more about establishing measurement-based care approaches. When you look at what the quality measures we have now, Andy alluded to the fact that there's a well-known Donabedian model for quality measurement of structure, process, and outcome. And really, a lot of what we focus on is primarily issues around process, as he noted. We have a limited investment, actually, in measure development that's been there over time. And we don't have great data sources. As I mentioned, the high-tech exclusion. We don't really have an ability to measure the content of psychosocial care. We simply know that a 45-minute visit was done. We don't know what the content of that was, whether it was evidence-based, whether it was simply chatting. For the most part, we've been looking at claims data as a way of establishing quality. And that's really like looking under the lamppost for your keys. The process measures are not really letting us know whether we have evidence-based treatments and whether measurement-based care is being provided. And when you look at a lot of the quality measures that we're using, not a lot of them are really associated independently with outcomes. So we really haven't made any progress on improving the quality of care. This is something from the latest National Healthcare Quality and Disparities Report. And basically, they called out behavioral health as being a particular problem in terms of the lack of improvement and, in fact, actually sort of lower rates of quality have happened over the recent years. And here's one example. This is actually not a great measure. It's a process measure looking at people who are discharged after a psychiatric hospitalization. And as you can see, over the past 15 years, there's been absolutely no improvement. In fact, it's actually gone down. And when you think about it, it's really hard to get somebody who's seriously mentally ill into a hospital nowadays. They have to be pretty sick. The average length of stay in a psychiatric unit is the same as for an MI, 5 to 7 days. And then people come out after that experience and have very little connection. More than half of them have very little connection with any kind of outpatient care. Talking about the movement to value-based care, several months ago I gave grand rounds for CMS, and this was the title of my talk. And if you look, out of those top 10 reasons, 2 through 7 are all about measurement and quality measurement. And so this is where we need to make the investment. So why don't I stop there and let Dora, you going to go next?
Yeah. Good morning. Thank you for inviting me here. I feel like that was a bit of a setup, and not in a positive way, for all the problems. And then it's like, okay, CMS, how are you going to fix all of this? But it is wonderful to be here and to share some of the work that we're doing in this space. It's also wonderful to connect with see some of my older colleagues here on the stage and in the audience. I had a little bit of trepidation. I came in just as we were talking about radical hope, and I'm like, oh, our panel is focusing on quality measures, and it's quite a sharp departure potentially from radical hope. But we do have radical hope in this space. I think, as many of you know, behavioral health care is a top priority for this administration, all the way to the top, with our president speaking often about the need to invest more in mental health care and really charging all of the agencies within HHS to think more about what it can do, what are the actions that we should be undertaking to improve behavioral health. As part of that, some of you may be aware that HHS has sponsored a number of internal-facing committees that are tackling some of the major challenges in this space, whether it's access to integrated care or suicide, opioid overdose, or thinking more about children. Across the whole gamut of issues, there are 6 different subcommittees, and a year later, we think that we've made meaningful progress across many of these areas. And I would have to say, certainly being at CMS, we are fully aligned, fully supportive of this administration's charge. We previously had a major initiative focusing on the opioid epidemic, and we have branched out to think more holistically about behavioral health care. Behavioral health care is one of our cross-cutting initiatives at CMS, meaning that is a top priority across all of the various centers, whether it's Medicare, Medicaid, CHIP, thinking about the marketplace plan, certainly for our center CCSQ. And so as part of that, it very much reflects the situation with our beneficiaries. 25% of Medicare beneficiaries 1 in 4 have a behavioral health condition. 28% of our Medicaid beneficiaries have a behavioral health condition. And Medicaid, CHIP, is the nation's largest payer for behavioral health care services. So whether we think about the health toll for our beneficiaries, if we think about the financial toll for our health system, needless to say, behavioral health care has and will continue to be a top priority. A little over a year ago, we released our own 5-part plan, and access to high-quality care for behavioral health care services was one of those charges. We're also focusing on specifically more effective pain treatment and management. We're focusing on SUD. We're focusing on mental health care and data, amongst the other areas. But I think even a year later, we still have been able to report some impressive progress, and I'm going to share a few examples here today. I am going to start with access to workforce. Certainly, as the nation's largest payer, we have important policy levers at our disposal, and I think because we are in the thick of reviewing thousands and thousands of comments in response to our proposed 2024 physician fee schedule, I thought I would share some of the examples of how we're trying to address the behavioral health crisis in that role. In that role, for the first time, CMS has proposed to allow marriage and family therapists and mental health counselors to both enroll and to receive reimbursement through Medicare. And I think that gets to some of the point that Dr. Pincus was making. It doesn't always have to be a psychiatrist. It doesn't always have to be a physician. We really have to think about who are the other providers that can help to fill the gap in care. In addition to those proposals, we've also sought comment on increasing payment and coverage for intensive outpatient behavioral health services, crisis psychotherapy, other health behavior assessment intervention services by not only marriage and family therapists, mental health counselors, but also licensed clinical social workers. And there's been a whole other host of other flexibilities if you think about telehealth or audio. We think that through PFS, we've really signaled our commitment, again, to increase access, think about payment, consider workforce in the behavioral health care space. Beyond Medicare, as I mentioned, obviously Medicaid is a critical payer. And if we think about children, I also picking back on one of the questions from the former panels, how are we helping schools? And as one example that I could note is that we have announced that we intend to establish a school-based services technical assistance center to really help states who want to do more to provide behavioral health care in school settings. But even aside from this example, Medicaid is increasingly a focus across all of our efforts at the center, and I think some of the models at the CMS Innovation Center help to underscore that important point. As example, one of our models, Integrated Care for Kids, is specifically focusing on how do we identify children on Medicaid under the age of 21 that have significant mental and physical health needs, and how can we help to connect them to care. And the second part, in addition to it being Medicaid, in addition to being one of CMMI's few pediatric-focused models, it also picks up on another point that's been made by Dr. Bindman and Dr. Pincus, is that we have to think beyond the medical model. We have to think about how can we better integrate community health services, community health interventions into the clinical care. And as one of the key outcome measures that matter, is foster home placement for children in the INC model, in addition to some of the more traditional medically focused outcomes. And so we're pretty excited about that model. We have another model that's focusing on pregnant women with opioid use addiction. We've also signaled, I'm not trying to make news today, we've also signaled that we have another behavioral health model that's under development. I think that one too will address issues, again, with especially thinking about community-based providers, thinking very much about equity, and also integration. How can we do a better job integrating physical health services, clinical service into behavioral health settings and vice versa. So through the CMS Innovation Center, we're certainly trying to continue to think about how can we expand access, bring in more workforce, and focus on, again, the measures that matter. What are some of the outcome measures? That being said, and maybe I'll focus for my last couple of minutes on quality measurement. I will say, if you look at across our 102 behavioral health measures, we maintain a quality measure inventory, and we looked at how many behavioral health measures are actually in there. Many, if not most of them, are in fact process-based for the reasons the science is now always advanced, so it's easier for claims, thinking about provider burden. But that is the issue certainly we're focusing on. We have already said that we're continuing to innovate in this space, and as one example, we introduced a new quality measure around patient engagement for inpatient psychiatric facilities, that it will be a patient experience measure. We think that that could help to provide important information across our providers. We have also proposed a new measure of the median time from arrival at emergency department to discharge across a number of the conditions, but including among those is the time to discharge a patient to an inpatient mental health facility. So in addition to our current measures, the measures that we're trying to develop, we are also very mindful that we have to harmonize our measures, align the measures across programs. We can't have just a set of measures for Medicare, a set of measures for Medicaid, a set of measures. How do we align across the programs and think of a core set of measures that could help us look at patterns, trends, identify disparities, reduce burden, and that we can also then maybe, ideally, align with commercial payers, and so it's across Medicare, Medicaid, and the commercial space. And so earlier this year, we announced the Universal Foundation of Measures. There are 2 behavioral health measures for adults. There are 5 for the pediatric population. This is the earliest, or certainly the early days, we're trying to see how successful we will be in terms of aligning across the programs, but we just think that that's very much a critical priority. So again, I'm happy to take more questions, but we just really think that quality measurement as part of our payment and reporting programs, as part of our models, is just a key consideration for having, for really seeking to improve the quality of care that our beneficiaries are receiving and being wise stewards of taxpayer funds. So I'll end with President Biden. If you look through his quotes, he likes to say mental health care can be life-changing and even life-saving. He also likes to say mental health care is health care. Our vision at CMS is for behavioral health that all people we serve across Medicare, Medicaid, and the marketplace have access to person-centered, timely, and affordable behavioral health care that is life-changing and life-saving, that can enable optimal health and wellness. And so thank you again for having me, and I look forward to the discussion.
Okay. These are tough acts to follow. And I should note that I am not a doctor. I'm just a PhD economist. And so I don't ask me anything that's actually very specific. I have to float at 30,000 feet. I want to start off by saying that many of the things that people are concerned about, complain about in the mental health system, things like workforce, access, fragmentation, these are ultimately all quality problems. Quality is the essence of everything that we're doing here. Everything is on your head, Dora. It's all you. And that's not unique to mental health. It's also true in the healthcare system as well. Tony pointed out that we're trying to do this value-based processes, quality-based performance, all the way through the healthcare system. But one of the things that we know, and this is my frequent co-author, Richard Frank, and I always say this, all of the problems in the healthcare system exist in the mental health care system, only more so. Whatever you think is hard in healthcare, it's even harder. It's the same thing, but it's even harder in mental health care. And let me just lay out why it's harder in mental health before we go on, and then I'm going to stay at 30,000 feet and talk about other things. But first of all, it's really hard to know what's going on in mental health. There's not a lesion. There's not a blood test. That makes it very hard to do quality measurement, and it's very hard to audit quality measurement to see transparently into what's going on in the system. There's tremendous variation in the severity and nature of the problems people have within mental health. It's a very big category that has a lot of different stuff in it. Not only a lot of different kinds of problems, a lot of differences in the kinds of treatment people get, and way, way more difference in the kinds of providers giving that treatment in mental health than we see in general health care. And I should add, a really lousy literature on whether it makes any difference which provider type you see. So we actually know very little about whether it matters, whether people are seeing geriatric psychiatrists or social workers or anything. and that's a very big concern. And then there are strong placebo effects in mental health, which makes testing quality measures very hard. And there is this problem of the therapeutic alliance between the patient and the provider, which is uniquely significant in behavioral health. So all of these things make quality measurement and quality-focused care much harder in behavioral health than elsewhere. What I want to talk about today is kind of the challenges of existing quality measurement, and then actually throw out some really new directions and try not to spend too much time being the skunk at the garden party. So let's think about the existing measurements. The first ones that we think about really are outcomes. Are people doing better? In an ideal world, I think everyone would agree that outcome measurement is a way to go. But it's very hard to do here. We could directly measure outcomes, which is what we do in like drug trials of depression drugs and so on, self-reported depression scores. Providers ought to be doing this as a matter of course to see how people are doing. I would say they should also be measuring functional outcomes. How are kids doing in school? Whether people are employed or not, whether people with severe mental illness have housing. These are things that providers ought to be tracking. But I think they are very hard for measuring provider quality. They're costly and very incomplete. Not everybody is going to participate in these processes in a regular way. They are highly manipulable. And we've already seen that these things can be manipulated because risk adjustment in the Medicare program, one of the big challenges is often around behavioral health measure. So I think it's very hard to do standard outcome measurement of regularly measured outcomes. A second way to think about outcome measurement is to look at the really severe adverse outcomes, emergency room visits, inpatient stays, suicide attempts. There is some evidence, hallelujah, a little bit of evidence, that these really bad outcomes are avoided with better care. I have to say that the quality of that evidence is not what any of us would like it to be. We would be doing a lot better in this space if we actually understood more about how processes feed into outcomes. But if processes didn't feed into outcomes, what are we all doing here at anyway, right? If we can't even figure out how we should be getting the better outcomes, then we're very muddled. We should be tracking these very severe outcomes at the provider level and at the plan level. We should make them very transparent. But they're not good measures for assessing individual providers or probably even plans. These are very rare events, so we need big samples. And there are real concerns about the incentives for avoiding sicker patients if you actually measure and report and incentivize things that are related to these very severe outcomes. Okay, so outcomes really problematic. What about processes? Are providers doing the right thing? Well, what on earth is the right thing? There's tremendous heterogeneity in treatment, so it is very hard to describe what the right thing is. It's really hard to map what happens in therapy offices to what the right thing is. When providers say they are doing CBT, the evidence suggests they might be doing CBT. We don't really know. It is costly and hard to map that kind of granular processes at any level. So instead we go to kind of lowest common denominator access measures. Did you see a provider within 7 days after hospitalization? Or provider ratios. How many psychiatrists are there per so many members in your plan? These measures are not satisfying. I don't think they map either into effective processes or into effective outcomes. They're just things we can do. So what can we do that's better than that? I'm an economist, so I like light posts. I want to use utilization data because we've got it. I think that what we want to do is be more consumer-oriented in thinking about those utilization data. I was really struck by Teresa's remarks about using new sources of data. Can we look at utilization data in a more systematic way to see whether patterns of utilization reflect what we think is good care, not at the individual encounter level, but at the provider or the plan level? So, for example, are rates of diagnoses of mental health conditions what we would expect in this population or not? If a primary care doctor is never reporting diagnoses of mental health conditions, is something going on there that they're not actually catching something? Can we do that at the plan level? I think better than that even are rates of subsequent care, because this really gets at consumer choices. Do people who have an initial visit for a mental health problem, do they return to the same provider for follow-up care within an expected amount of time? So they have to do that. It's completely driven by the consumer. But if the consumer is not doing that, there's something wrong with the quality of care. That doesn't mean everybody should be returning for subsequent visits. That's not what I mean. But are we seeing rates of this that are compatible with what we think is good care? That will capture provider availability, and it will capture the quality of the therapeutic alliance. Maybe there are lots of doctors in the plan, but nobody likes them. That's not actually providing you with quality availability. Do people who have an initial diagnosis in primary care get a specialty care follow-up and then return to that specialty provider? Do people refill their prescriptions at expected rates? Do people see a second provider and a third provider, which suggests that they're not very happy with the care they're receiving? So I don't know what the measures ought to be, because as I said, I'm an economist, and I don't know anything about how you actually treat people. But I do think that we can think about measures that using data that we already collect, using utilization and encounter data that we already have to get beyond where we are now. It's hard to do it at the level of the individual provider, although I think for some cases we can, but at the level of employer groups, Medicare Advantage plans, random assignment into Medicaid, we might be able to look at what reasonable care looks like in a population and develop some benchmarks. The goalposts will be changing all the time as everybody adapts to them, but I think this is a way to actually make a little bit of movement on a front that has been quite stalled. And I just want to add one plug, which is that this is also a way to capture equity, because we know about the characteristics of plans, so we can ask whether our underserved minority populations are going for the second and third and fourth visit when they should be. Are our rural populations getting this kind of care? I think there are things that we can do even with respect to equity using data we're already collecting. So let me stop there.
Well, terrific. Thank you to all of our panelists. I really appreciated each of your comments, and maybe try to see if we can have a little bit of a conversation both amongst ourselves and then invite members of the audience to ask us questions as well. You know, I was really, I guess I want to inject a little bit about some of my own challenges and how I've seen some of what's gone on here. You know, it was mentioned in my introduction that I'm still relatively new to KP. I'm coming up on about my third-year anniversary, and part of what attracted me to KP was the challenge that was given to me by our CEO, who said, I think it's time to really shift the conversation about quality toward outcomes. And we have really tried to move in that direction in cardiovascular disease, in cancer care, in maternal health, and we're trying to do it in mental health and wellness as well. We are measuring things like response to depression treatment and suicide rates among our population and so forth. But you know, one of the things that wasn't explicitly mentioned that I just want to raise is that as an organization that maybe has a bit more infrastructure because of our closed network and ability to kind of really look at our full population, we're in a position to try to lead in this space, which is very exciting, and again, why I came to KP. But it's also a little bit scary in the sense that we're walking out on the ledge and we're doing something and beginning to put out information about our outcomes, and we've got no benchmarking because others aren't coming along with us. Are there ways that you can see to help entities like KP, others that are moving toward value-based care, to feel safe as they try to take the chances to move the field in different ways? I mean, all the things that you raised about the challenges, but can we create an environment that allows for the innovation to happen in this space without it becoming just, gee, KP, I don't think your outcomes look so good. And meanwhile, there's no context to evaluate, actually, are they amazing or are they mediocre or what? I mean, I personally think they're probably amazing, but you know, it's very hard to know without benchmarking. So any thoughts about how we could allow the community to evolve by allowing leader entities like KP that are ready to take the step, and not sort of punish them for trying to do that?
Well, two thoughts about that. Number one is you do have a really unique capacity to apply measurement-based care. In many ways, as you think about it, really the way we treat patients should look more like the way we treat people with mental health problems should look more like the way we treat people with diabetes and hypertension and so forth, where we're keeping them in the system and making sure that we're tracking whether or not they're getting better. Just doing that is key. One of the problems is if you look nationwide, there's a study that we did a number of years ago at episodes of behavioral health care. What do you think the modal number of visits is? One.
One, okay.
Yeah. That's why there's the potential to do
the
more.
the median is 4.
Okay. Yeah.
But that's, but people drop out of care.
Yep.
We need to have what I term ruthless follow-up to make sure that they keep engaged. Not just ruthless follow-up, but also to make sure that we are doing some sort of systematic longitudinal assessment to see whether they're getting better. Not just for accountability, but also for how you're applying care, decision-making about what kind of care they should get and administering that care. If people aren't getting better, you need to think about how do we intensify care. To have that kind of measurement-based care system. In fact, one of the things that I've suggested in some other forums is that we need to have, in some ways, a measurement-based care kind of, label for places that do that and do that effectively. And then you're less out on a limb if everybody else is measuring in some ways.
Yep.
And it's not just about some absolute value, but looking at improvement over time.
Yep.
Yeah.
I mean, I think that creating these benchmarks could be done either by having everyone be required to create the benchmarks, but I also think there's a lot of data out there that you could use to describe benchmarks in different kinds of plans. There is a lot of utilization. I mean, one of the things I like about Lamppost is the data exists. You could do this, right? You could pull Medicare data and look at what's happening to people. And you could report what the national averages are and what you look like. At some point, there have been health systems at various times that have looked at these. I do think there's a lot of scope with these really severe adverse event indicators. They are not very manipulable. They shouldn't be happening. That doesn't mean that they won't happen. People die of all kinds of things. Things will happen. But if you have elevated rates of these things, that's not good. You could look within KP and compare areas. And I think it helps you get to this linkage, which I think is so key between what the really severe outcomes look like and what the process of care needs, that matches up to them looks like.
Yep. Yep.
So the only thing I would add, I mean, it is difficult to be a leader in this space. When CMS adopts a measure, generally it takes from the time a measure is being conceptualized to the time it's in use in our programs is about 5 years. And so for those on the cutting edge, it could take CMS up to 5 years to catch up. But that is, and then there's also issues on the Medicaid side. As you know, at least half of states have to have the measure in use for it to be part of the course. I mean, there's a lot of different procedural barriers. But I do think that's part of the promise, frankly, for the CMS Innovation Center. I mentioned they have the INC model, pediatric behavioral health. We have the MOM model, maternal behavioral health. We're working on another model right now. But I didn't even mention, I mean, there are behavioral health measures that have been included and are Making Care Primary, our latest primary care model, other models. And even though it seems like a long time for models to go through, even as one model is launching, we're usually 1 year already in the development of another model that's building on, iterating on the last successor model. And so that provides an opportunity to include new measures, to test measures, to really build upon what we're learning in the field so we're more timely able to, in many ways, at least for CMS, kind of push the edge. I certainly understand it takes a long time for the measures generally, because if you're going to condition payment on a measure, then there has to be some assurance of it being validated and all of that, I understand. But I do think that there are opportunities at CMS to really think through how can we start to include measures that are being developed newer in this space. And I think to the extent when we include something, even in a model, our research models, we call it models, others might call them research projects or demonstrations, but we include that in a model, it gets a lot of attention. It is a strong signal that this may be one of the areas that CMS intends to pursue and I think could be a really worthy conversation.
Great. Well, thanks. You know, I've also was struck, Dora, you were describing something I think that's a real step forward at CMS, which is to create the alignment across the different programs for measurement. So well done there at CMS, long time coming, but I think a good direction. Maybe tied to that a little bit, and sort of curious about perspectives on this. You know, just when you look out at the quality measurement field, it seems like our approach has been, let's let 1,000, then another 1,000, and another 1,000 flowers bloom. And there's all these, you know, you mentioned it yourself, there's 102 behavioral health measures at CMS. As you said it, I was thinking of that Bruce Springsteen song about how many cable channels there are, but nothing to watch. You know, you know, to some extent, do we need to almost get to less better ones as opposed to more? Or what's the process, you know, that we see to get there? Is it just because we still haven't gotten it right, we still are in that kind of like innovation phase, or is there some value of thinking about, let's hone it down and really figure out what things seem to be the right one? I mean, Sherry, you were trying to maybe go there a little bit. I'm curious, you know, what's the best step forward for us? Is it still lots of things blooming, or is it time to start harvesting?
Well, I think the answer is probably a bit of both. I mean, we will say as part of our measure process, developing measures, we're also looking more about when we should be retiring measures. I mean, so as we learn more and know measures that are either topped out or ineffective, how do we get them off the list? And I think the Universal Foundation, I mean, that whole initiative in part gets at what you're saying, that there's too many, and if we can cull that down. And even for our MIPS program, if you're familiar with that, trying to think through what is a smaller set of measures that are highly relevant, particularly for certain conditions or certain provider types. So I do think you're starting to see us think about how can we start to shrink the measures filled so that we are focusing on those that matter the most. But that said, back to, I would say Dr. Pincus, he wasn't like, you know, his presentation, the reasons why value-based care won't work. I'm not sure how many friends he made at CMS, but I do think, you know, back to his slides and Sherry's point, this is harder to do in this space because the data and the evidence is just so limited.
Yeah. You know, one thing we haven't touched on so much is how much telehealth has changed what's going on in this space as well. And I'm curious, whether you think this is truly an innovation in a sense. Is it going to, you know, improve quality? What are its impacts in terms of you know, our ability to deliver and ultimately create the accountability around the care? I mean, what are the things that you're all seeing or hearing, or your sense of this? I know it's still early and it happened fast, you know, during COVID, but curious whether you see this as opening up new kinds of opportunities for measurement or assessment, accountability, and so forth.
So I think there's a couple of different things there. One is, obviously, it greatly improves the possibilities for both access and integration. I think the integration piece hasn't been exploited enough, but while there are lots of places that couldn't possibly co-locate a mental health provider, it isn't that hard to co-locate a connection to an online telehealth service. So you see a patient, and instead of sending them down the hall to a social worker, you send them down the hall to a room with a computer in it, and somewhere in Oshkosh, there's somebody who's on the other end of the computer. Just, it makes that way easier. I don't think we've figured out how to finance that or pay for it or anything, but it certainly raises all those possibilities. The other thing it does, and I think this is also a really, really tough thing that we're going to have to think through very, very carefully, and it kind of goes back to AI and so on. In principle, it can allow us to get inside the relationship between the patient and the provider. That really depends on what kinds of privacy protections we can enable. But you could imagine in another world, which I'm not even gonna, like, I'm an economist, I don't do this stuff, I keep like saying that, right? That you actually record those sessions and run them through an AI machine and say, you know, people do better when these are the things that happen than they do when those are the things that happen, not in an individual case. So I think there's actually great potential here on several levels. There's also enormous potential for misuse.
Yep.
Just, I would say that there actually are companies that are doing that right now. So there are companies now that record these sessions and that extract three things out of the session. Number one is they're able to assess through AI whether or not what's going on in that session in any way resembles evidence-based care. Number two, it's able to abstract from that information also how well the patient is doing, to actually put together a kind of a measurement-based care assessment. And number three, they're able to summarize that session and enter it into the electronic record without the therapist having to write everything up.
Yeah, I think there's great potential for that.
Yeah, great. And do we know anything at this point about the effectiveness of care delivered through telehealth versus how it's delivered face-to-face?
Most of the evidence is that there's not a big difference.
Yeah, okay. Now, that
obviously,
would be
in certain
'cause-
circumstances, there is.
Yeah.
But, for the most part, there's not a big difference that's been determined.
Fantastic. Great. I want to turn to the audience and see what kind of questions you have. Yeah.
Hello, I'm Clece Erickson from George Washington University, one of the couple of researchers in the room. And I've been doing a lot of workforce research around substance use disorder. And one of the things I recently revealed in a paper that came out in JAMA is that when the waiver was a thing, only 40% of providers with the waiver actually prescribe buprenorphine in a given month. And many drop out or never prescribe. And so I'm a little worried now that the waiver's gone, which I think is an excellent thing. Is that going to be enough? And your conversation today made me wonder, is there a potential measure around that could be developed around if you're a primary care provider and you have a patient with a diagnosis of opioid use disorder? This possible process/quality measure would be like, what % of your patients with opioid use disorder are on buprenorphine? I think because that is the thing that should happen, and you could maybe make exceptions for
and stay on buprenorphine for some period of time and have follow-up visits. And it seems to me like there's a lot you could do.
It seems like that is potential for a measure.
And even though I think CMS is really important and all of that is really important, a lot of this should really not be coming from CMS. A lot of it should be coming from health plans doing it themselves.
Absolutely.
Yeah.
I don't think you should be waiting for in fact, it almost would be better if CMS could see how these things are working in the world and then decide which ones of them it wants to adopt for payment purposes, as opposed to straight up quality improvement, which is not about payment, but just straight up quality improvement.
And to that effect, I think group practices could actually do the same thing, like hold their workforce accountable for doing this. Can I add one other comment too, which is I've also identified through my research that primary care providers, as you all have mentioned earlier, are a big part of treating health workforce, including for serious mental illness. And I haven't heard any mention yet today of like hub and spoke models or e-consults or Project Echo. And I was wondering how you all think that might fit in with quality.
I would say for CMS, as part of the CMS Innovation Center, they released their specialty integration strategy. I'm not sure the right term. It can be found online. But thinking through how they can more strategically use the different models, including e-consults, as you mentioned, other models, to expand the footprint, that's definitely been contemplated, and they're trying to think through how can they include that approach in more of the models. But at the same time, though, I know that there's a lot more that we probably could and should be doing in this space.
I just wanted to comment, one of the things, thank you for bringing up the primary care issue. One of the things that we're doing at KP is it's really trying to roll out the collaborative care model, right? And to partner behavioral health specialists in primary care settings and to really bring that expertise, to bear in a timely way. But it is striking. I mean, that model's been proven to be very effective. Actually, we've known that for quite a long time through a lot of studies. And yet, if you look around the country, its uptake is extremely low. And it kind of speaks to some of the challenges we have around trying to move evidence on delivery models into care, right? If collaborative care had been a red pill and we got it through the process, the FDA would have approved it and everyone would be taking the collaborative care red pill years ago. And so it really speaks to a challenge I think we have. And I'm curious, are there ways to accelerate when we have delivery models proven to be effective, like collaborative care, using primary care with behavioral specialists to move things along more quickly?
And I don't ever want to speak for my colleagues in Medicare, but they have released a payment code for collaborative care as one way to try to incentivize, but it's still just one small step, and from the way that Sherry's shaking her head,
I
highly insufficient
think
step.
the challenge is that trying to incentivize institutional change by changes in marginal payment rates is a really tough game, right? That's just you're not asking people, so the doctor doesn't even get reimbursed for prescribing Prozac. Prozac and collaborative care probably started at the same time, right? Collaborative care went nowhere, and in 2 minutes, Prozac took over. Not only did Prozac take over, what I find really interesting is that before Prozac came on the scene, the question we were all engaged with is, why don't primary care doctors diagnose depression? They don't ever diagnose it. And then Prozac came and they began to diagnose it. And so that actually tells us something, right? What does it take to make this happen? It takes the primary care doctor feeling like this thing is actually making me be able to do my job that I do every day better. Not that I get paid for it more or anything, but my patient comes to me, they want something from me, and this thing enables me to do it for them. And that's what led them to start screening for depression. We taught them a million things that didn't work. We did like payment, didn't work. Finally, they had the little red pill, and they were like, you know what? I write this thing, and they feel better.
Yeah, well, ease of administration has been noticed in other businesses, and so I do think that that's a good point. Yeah. But I think primary care doctors do believe in collaborative care, but at the ease of being able to implement it is...
It's really hard.
Yeah.
Well, I think part of it is that you're paying for a team.
Yeah.
And it's hard to pay for a team. And I think that's really, unless you're in an organization like KP, where you by definition, you're a team, it's hard out in the sort of real world of, wild world of practice to actually pay for a team. And that's, I think, the real challenge. I think the other issue is to think about how do you really engage, even now with the collaborative care codes, how do you make it easy for them to actually get paid? Because I think that's really the challenge that you hear out in the field. The other thing to think about is, again, thinking about it from an integrated care point of view, is how do you get better general health care, preventive health care, chronic disease health care for people with serious mental illnesses. There's very little incentive for even to have people like that in your waiting room as a primary care doc. Yeah. I remember when I was, working at the community mental health center, it was really hard to get my patients into primary care practices. Yeah. And actually to keep that as a kind of a quality measure, there's actually a fairly simple strategy. We do, for people, for example, that have both diabetes and psychosis, we can look at whether or not looking at the diabetes measures at the segment of people who have psychosis and see if there's a difference. So that, if you're looking at hemoglobin A1C, is there a big difference between the segment of people? It's like a disparities analysis. Yep. Between people with serious mental illnesses in terms of the way in which their hemoglobin A1C is going. Or for that matter, what about their immunizations? What about their cancer screenings?
Mm-hmm. Yep. Well, you've provided a perfect segue to bring this panel to a close. One is, you said the team is important, and we've had an amazing team here. And so, first of all, I want to thank this team of panelists who've done a great job to bring out the important issues around measurement and improvement in mental health care. And Dr. Pincus, you also highlighted some of the workforce challenges, both on the mental health side and just mentioning primary care as well. And we'll be having a panel after lunch to talk about some of these workforce issues. But please join me in thanking our panelists, and we'll exit the stage. So thank you.